Hello students, so a very good evening. We are starting this Sankalp series for Pediatric section NEET PG and INICET 2026. So let's start without further ado. There was already some technical glitch, so we don't need to waste any more time. Let's start. We have our first question with us. We have a 3-month-old infant whose head circumference has increased by 6 centimeter since birth. And how you should interpret this clinically. The first option says that it is pathological macrocephaly. The second option says that this is significant microcephaly. The third option says that this is expected normal development for the child. And the third is early closure of the anterior fontanelle. So what do you think would be the correct answer over here? So to interpret anything, you should know what is normal. Then only you can know what is abnormal. Macro, you know, big head. Micro, you know, small head. So let's understand what is the normal rate of increase in the head circumference of an infant. Firstly, the normal head circumference at birth is 33 to 35 centimeter. We have 33 to 35 centimeter. This is 60% of the adult size. Then how does it grow thereafter? In the first 3 months of life, the increase is 2 centimeters per month. Thereafter, in the next 3 months, that is 3 to 6 months of age, it's 1 centimeter per month. Then we have 6 to 12 months where it is 0.5 centimeter per month. So in the first 3 months, it's 2 into 3, that is 6 centimeters. Sorry, 2 into 3, that is 6 centimeters. Then we have in the next 3 months, 1 into 3, that is 3 centimeters. And thereafter, 0.5 into 6, that is again 3 centimeters. So you can see in the first year of life itself, 6 plus 3 plus 3, there is gain of 12 centimeters, right? So if at birth, say head circumference was 34 centimeter, at 1 year of age, it is going to be 46, right? So at 1 year, it will be 46. In the next year, the increase is 2 centimeter in that whole year. So it becomes 48 centimeter. This is 90% of the adult size. And thereafter, at 12 years of age, adult head size 52 centimeters is reached. So in this question, they are asking that this 3-month-old baby has increased 6 centimeters since birth. So this is nothing but normal. I know that in the first 3 months, the gain is going to be 6 centimeters. So this is an expected normal development. So the correct option here is option C, right? This is option C, expected normal development. Let's move to the next question. The next question we have is, which growth pattern in Scammon's classification is famously described following a sigmoid or S-shaped trajectory? The options we have are neural growth, gonadal growth, lymphoid growth, or somatic growth. What is the correct answer over here? This is nothing S-shaped. Remember, S somatic, this is somatic, right? So let's understand these human growth curves or Scammon curves. I have 4 curves with me. These are the human growth curves or Scammon curves. Let's look at the first graph. What is happening over here? Initially, there is exponential growth of this tissue and thereafter little to no growth. So the first 2 years of life itself, the growth is enormous and thereafter little to no growth. We just read head circumference, it reaches 90% by 2 years of age. So this is nothing but neural growth. Nothing but neural growth. Then we have this curve where there is a peak in 4 to 8 years of life. This is nothing but lymphoid growth. Then we have option C. This is nothing but S-shaped, typical S-shaped or sigmoid-shaped curve. Can you see? Initially, exponential growth, then little to no growth, then again exponential growth. This is an S-shaped curve or sigmoid curve. This is for somatic growth. That means your bodily growth. The weight initially doubles, triples in the first year of life. But thereafter, there is little gain. And then again, as the puberty is hit, again weight and height increases. So this is nothing but somatic growth pattern. Then we have option D. What is there happening in option D? Halt. And again there is a spurt. The spurt coincides with puberty. So this is nothing but gonadal growth or sexual growth. Gonadal or sexual growth. So these are the four Scammon curves, and this concept is very frequently tested in your exam, be it NEET PG, INICET, and even in the FMGE exam. This is one of the hot favorite questions of the examiner: human growth curves or Scammon curves. This you cannot afford to mark wrong, right? So here the option is, the correct answer is S-shaped trajectory, sigmoid trajectory, somatic. Remember SS, S sigmoid, S-shaped, somatic, right? So the correct option here is D. Now let's move to the next question. A child has reached 90% of their adult size. Based on the standard growth curves, how old is this child likely to be? 1 year, 2 year, 5 year, 10 year. The very same concept. I told you the neural growth happens maximum till 2 years of age, and thereafter little remaining growth happens. So 90% of the adult head size is reached by 2 years of age. 2 years of age. Right? So correct answer here will be option B, that is 2 years. Now let's move to the next question. A 12-month-old infant was weighing 2.75 kgs. What is the predicted weight at 1 year checkup? The options we have are 5.5 kgs, 7.2 kgs, 8.25 kgs, or 9.2 kgs. So let's now understand how weight increases after birth. So normal, if you talk about the average birth weight in India, it's 3 kgs. And in the first 7 days of life, there is no gain in weight. There is actually loss of the weight. So for 7 days, there is something that is known as physiological weight loss. Every baby is going to lose that weight. Physiological weight loss. The term babies, they can lose up to 10%, which is again regained by day 10 of life. And preterm can lose up to 15%, which is regained up by day 14 of life. After that, there is increase in the weight. Initially, every day, the infant can gain 20 to 40 grams per day. 20 to 40 grams per day till 3 months of age, and thereafter 300 grams per month till 1 year of age, right? And to simplify the concept, we have a ready reckoner. Say birth weight is X, then by 5 months it becomes double, so it becomes 2X. By 1 year it becomes 3X, by 2 years it becomes 4X, by 3 years it becomes 5X, then 6X by 5 years, 7X by 7 years, and 10X by 10 years of age. So here they were asking that a child has come up to you at 12 months of age. That means at 1 year of age. So I expect the weight to be tripled. So 2.575 into 3, it comes out to be 8.25. 8.25 kgs. Right? So the correct answer here is going to be option C. Now let's move to the next question. In Tanner stage 3 of male puberty, which of the following clinical findings is typically absent? Coarsening of hair, penile growth, peak height growth spurt, or enlargement of testes. We all know that growth spurt happens at stage 4 of Tanner's, right? So this is something which is going to be absent, rest all is present. So let's revise again the Tanner staging in male and female. So what is Tanner staging? It is nothing but sexual maturity rating staging. We have 5 stages, 1 to 5. 1 and 5 is going to be same. Same for both male and females. 1 is prepubertal stage, 5 is adult-like stage, right? In stage 2, what is happening? The increase in the size and testes will happen. There will be sparse pubic hair and scrotal reddening is going to happen. Then in stage 3, now the hair will start to curl and coarsen, and there will be increase in the penile length first. In stage 4, now the hair will become more coarse, more curly, and now along with the length, width also increases. The pubic hair would be just like the adult pattern, but no pubic hair on the medial thigh. The adult-like pattern where the pubic hair are present on the medial thigh as well will be seen in stage 5. So this is Tanner staging in males. Now let's understand Tanner staging in females. 1, 5 would be same, 1 is prepubertal, 5 would be adult-like. Firstly, in stage 2, what happens? Breast bud is going to appear and you are going to appreciate very sparse pubic hair. In stage 3, growth spurt happens and there is a development of increase in the breast size and secondary mount formation, contour separation. In stage 4, it is just like the adult pattern, but no pubic hair on the medial thigh. So this is nothing but sexual maturity rating in both males and females. Growth spurt is the question that they ask. In female, growth spurt is seen in stage 3, and in males it is seen in stage 4. So the options over here you can see: coarsening of pubic hair, penile growth, enlargement of testes, all of these would be there in stage 3, but peak height growth spurt is going to happen in stage 4. So this will be absent. So the correct option here is going to be option C. Right? Now let's move to the next question. A 7-year-old child with short stature has bone age that perfectly matches their chronological age. So bone age is equivalent to the chronological age. Both parents are also short. What is the diagnosis? So always remember, parents short, child short. This is nothing but familial short stature. Familial short stature. What happens in familial short stature? I am short because my parents are short, because my genetic potential is such. So in that case, if you look at the bone age of this child, that is going to match the chronological age, right? But all of these, bone age, chronological age, will definitely be less than the height age of this child. So this is nothing but familial short stature. With that, let's revise the physiological short stature. So in physiological short stature, we have two entities. First is constitutional delay in growth and puberty, and the second is familial short stature. Familial short stature we just read. What is familial short stature? I am short because my parents are short. So there's going to be history of short parents. The final height of this child is also going to be short. The height age. What do I mean by height age? Let's say I know a normal length of a child at birth is 50 centimeter, and at 1 year it's 75 centimeter. So if I say a child's length is 75 centimeters still at 2 years of age, that means the height age of the child is less, right? So this is going to be less over here, because obviously the height is less. Bone age here is normal. The child is growing up to his potential, so bone age is here going to be normal. So remember, chronological age will be equal to the bone age, but both of these would be less than the height age, right? So height age is less than chronological age and bone age. Now let's understand constitutional delay in growth and puberty. Here what happens, the parents are of normal height, but they have a history that their puberty came a bit later. They gained height a bit later, right? Remember one of your friends who suddenly grew overnight after summer holidays in class 9th and 10th? Otherwise, the child was short, maybe standing in the first or second place in the assembly line, suddenly goes to the back. So this is nothing but constitutional delay in growth and puberty. Right, this is nothing but constitutional delay in growth and puberty. What is happening over here? There will be history and delay in puberty in parents. The final height here is normal. Height age at present will be less. Bone age here is delayed. If you look at the relationship, then the bone age is equivalent to the height age, and overall this height age will be less than chronological age, right? So to remember this relationship is the problem for the students. Very easy way to remember. Always remember, whenever there is short stature, that means the height of the child is looking less as compared to his age, right? So height age less than chronological age, this is going to be constant. This is going to be constant, right? If we talk about familial short stature, the child's bones are growing as per his age, right? So here the bone age will be equivalent to chronological age. This is familial short stature. What about constitutional delay in growth and puberty? Here the bone age is slightly lagging. Bone age is as per his height. So bone age is equivalent to height age in cases of constitutional delay in growth and puberty. So just remember, this is constant. Height age less than chronological age. That's why it is short stature. Then bone age, you have to switch here and there. In constitutional delay, height age is equal to the bone age, and in familial short stature, bone age is equal to the chronological age, right? So this is the concept of bone age, height age, and next question is based on that concept only. So this question asks, if a child's height corresponds to the 50th centile for a 4-year-old, even though the child is chronologically 6, this value represents what? So they are saying the child's age is 6 years of age. That means if today is 2026, the child must have been born in 2020, right? So 6 years of age, but the height seems to that of a 4-year of age. So this value represents nothing but height age. So this is the concept of height age, bone age, chronological age. So let's just revise. What is chronological age? Simply the age, the years lived. So if a child was born on 1st December 2024 and today is 1st December 2025, the child is 1 year of age. So age since birth is nothing but chronological age. Then we have height age. Height age is the age at which that particular height is at 50th centile. As I told you, at 1 year it should be 75 centimeter. So if you're on graphs, that particular height is lying at the 50th centile, that particular age is going to be height age. And lastly, we have bone age that we calculate by the number of ossification centers. We have different methods: Tannis Whitehouse method, Blue-Ridge-Pyle Atlas, Bone Expert, which is an app. So all of these things come in handy when you evaluate the height of the child. Right, so this is about the concept of bone age, height age. Now following up this question, I know now most of you can answer this. Constitutional delay in growth and puberty, that is CDGP, is physiologically defined by which relationship? So we firstly know this is a physiological short stature, so height age is going to be less than chronological age, and this is constitutional delay in growth and puberty. That means my bone age will be equivalent to the height age. So let's look what option fits over here. Option B fits over here, right? So this is how you make out the relationship between bone age, height age, chronological age in both of these physiological causes of short stature. I hope you now understand what is the concept of this bone age, height age, chronological age, and how they are related in cases of both of these physiological causes of short stature, right? Now let's move to the next question. At what age does the upper segment to lower segment ratio typically reach 1:1? The options we have are 3 years, 5 years, 7 years, 10 years. So what is this upper segment lower segment ratio? If I make the child stand up like this, from the head till the pubic symphysis, this is upper segment. And if I subtract my total height, if I subtract the upper segment from the total height, the remaining is the lower segment. Why is this important? This is important when I am evaluating short stature, whether this is a proportionate short stature, whether this is a disproportionate short stature. So if this is a proportionate short stature, both upper segment, lower segment will decrease. So my ratio would stay normal. But if this is a disproportionate short stature, either the trunk is short or the limbs is short, then my upper segment lower segment ratio will be either increased or decreased as per the disproportionality, right? So firstly, let's understand what is the normal upper segment lower segment ratio. At birth, it is 1.7:1. Sorry, it's 1.7:1. At birth, at 1.3 years of at 3 years of age, it becomes 1.3:1. At 6 years, it becomes 1.1:1. At 10 years, it typically becomes 1:1, and thereafter the adult ratio, that is 0.9:1, or I can write down as 1:1.1 is achieved. Right, so this is the normal ratio, but if it is increased or decreased, that would be disproportionate short stature. It could be either a short trunk dwarfism or it could be a short limb dwarfism, right? Now let's move to the next question. The first tooth to erupt in the primary dentition is usually the lower central incisor. At what age typically this occurs? 4 months, 6 months, 9 months, 12 months. What is the correct answer over here? Yes, it's nothing but 6 months, option B. So let's understand these dentition. Very small concept, very high scoring concept. So we all know we have two sets of teeth. We have temporary teeth, also known as deciduous teeth, which are going to be shed down, and then come the permanent teeth. So deciduous or temporary teeth, 20 in number. In each half, we make this dental formula. So we have 2102, 2 incisors, 1 canine, 0 premolars, 2 molars. Then we have permanent teeth, that will be 16 in each jaw, 2123. 2 incisors, 1 canine, 2 premolars, 3 molars. So first tooth to erupt is lower central incisors at 6 months of age, and last deciduous teeth to erupt is the second molar. Then we have first permanent tooth to erupt, that is the first molar, and then we have something known as natal teeth, which are mandibular incisors present at birth. Timeline is what is very important. So remember the first deciduous teeth, the first temporary teeth, that is the lower central incisors, it comes at 6 months, and this whole set of 20 teeth, 20 deciduous teeth is completed by 2.5 years of age. Then we have permanent teeth. The first molar appears at 6 years of age. This is the first permanent teeth. This is also known as 6 years molar. And this finally, the permanent dentition is completed by 21 years of age. So this timeline is very important. These important one liners are very important, very high scoring. So let's move on to the next question following up that. By what age the child is expected to have a full set of 20 primary teeth? I told you deciduous teeth full is completed by 2.5 years. So the correct option here is going to be option B, 2.5 to 3 years of age. Okay, so next question is also following the same concept. A parent comes to you, a parent asks which tooth will be the first permanent one to appear at the age of 6. 6-year molar, remember? So the first molar is the first permanent tooth that appears, first molar. Now let's move to the next question. We are done with dentition. What is the developmental rule regarding the primitive reflexes and the attainment of new voluntary milestones? The first option says they must strengthen, B, they must disappear, C, they must become voluntary, and D, they remain as the basis for the motor skills. What do you think is the correct answer over here? They must disappear. Option B is the correct answer. Right? To attain new milestones, the primitive reflexes should disappear. To get into a new relationship, you have to forget your ex, right? So similarly, primitive reflexes must disappear so that new milestones can be attained. So let us quickly revise this laws of development. The first law says that development is a continuous process. What do I mean by the continuous process? The development is ever evolving process. You and me are still developing, still maturing. Development means CNS maturation, right? So remember, development is a continuous process. It depends upon the maturation of CNS, and the sequence and order will remain the same. That means firstly the child will learn how to hold his neck, then how to sit, then how to stand, then how to walk, then how to run. The sequence, this order will stay the same, right? There should not be any interruption in this order. The sequence and order will remain the same. And what is the direction of progression of this development? It's cephalocaudal. That means firstly head control comes, then my trunk control comes, then my limb control comes. So cephalocaudal, and within the limbs it's proximal to distal. That means my distal activity will come later on. My big bodily movements will come first. Right? So remember the direction of progression, cephalocaudal, proximal to distal. The fifth law, which was our question, primitive reflexes. The primitive reflexes must go to achieve the new milestones. Remember palmar grasp, it is a neonatal reflex. It should go so that the child can voluntarily grasp objects. Similarly, ATNR, when the child turns to one side, on that particular side there is extension of the upper limb and lower limb, and on the other side there is flexion. This will prevent the child to roll. So for rolling milestone to come, the child has to lose that ATNR. So primitive reflexes must go to achieve new milestones, right? And the last is initial disorganized masked activity is replaced by specific action. Firstly, the child has bidextrous grasp, then unidextrous, then pincer grasp, then the child can hold objects, scribble, make beautiful diagrams. So the initial disorganized masked activity is now replaced by a specific action. So these are the laws of development. This should be very well versed with you, right? And this direction of progression is very important because cephalocaudal proximal to distal is development, whereas growth is cephalocaudal distal to proximal, right? So it's very important that you remember these laws of growth and development. Now let's move to the next question. A child gains control of head before their trunk before their limbs. This follows which rule? So very simple, head before trunk, trunk before limbs. This is cephalocaudal, and we all know trunk before their limbs, so proximo-distal. So cephalocaudal and proximo-distal. Now let's move to the next question. We have a 9-month-old infant who has just developed pincer grasp. Which linguistic milestones usually emerges at the same time? So usually we know that pincer grass, the immature one, comes at 9 months and the mature comes at 12 months. And by 12 months of age, the child can speak his first real word. So the correct answer here is 1 to 2 meaningful words. Jargon speech, that is a vocabulary of 4 to 6 words and jumbled words, this comes at 15 months. Storytelling at 4 years. And what about this following the step commands? Let's understand. So firstly, first real word, remember, comes on the first birthday. Initially, the child can say monosyllables, bisyllables, but these are not the real words. Real words means the child knows the meaning of that word. So first, a real word, remember, at 12 months of age. Then vocabulary of 4 to 6 words or having a jargon speech. This is at 15 months. Storytelling comes at 4 years of age. Now let's understand these following commands. What is one step command? What is two step command? What is three step command? So if I ask a child, give me ball. This is one step, right? I'm just asking the child to give me ball. This is one step. This comes at 1 year of age, that is 12 to 18 months. Then comes two step. If I say pick up the ball and give me, this is two step. Firstly, the child has to pick up the ball and then give me. This is two step command. This comes at 2 years, so 18 to 12, 24 months. Then comes three step command. If I say go to your room, pick the ball and give me the ball. This has three steps, right? So this is three step command. This comes at 3 to 4 years of age. So this is the following commands pattern. Remember, one step at 1 year, two steps at 2 years, three step at 3 to 4 years of age. And when will be the red flag? Red flag will be if the child cannot follow two step command at 3 years of age, this is a red flag. And if the child cannot follow three step command at 4 years of age, this is again a red flag. So this is following commands and speaking the language milestones. So let's move to the next question. At what age a child is expected to be able to dress and undress themselves fully without any assistance? 3 years, 4 years, 5 years, 7 years. What do you think would be the correct answer over here? So what is easier? What do you think? What is easier, dressing or undressing? Undressing is definitely easier. We all like to undress. So undressing is easier. Undressing comes first, then dressing comes. So firstly, the child is going to do this dressing, undressing with help and thereafter without help. So undressing with help will come first, then dressing with help, then dress, undress without help. So firstly, undress with help, this comes at 2 years of age. Dressing with help comes at 3 years of age, and dressing and undressing without help comes at 5 years of age. And within dressing and undressing, one integrate action is buttoning and unbuttoning. So unbuttoning comes first at 3 years of age and buttoning comes at 4 years of age. So here the question was asking when the child will be able to dress and undress fully without any assistance, without any help. So this comes at option C, that is 5 years of age. Right? So let's start with the next question. Which figure a child can typically copy by the age of 5? Is it a circle, square, triangle, or diamond? At 5 years of age, the child can make a triangle. So let's remember these scribbling and making diagrams. So firstly, scribbling. Scribbling is this. This comes at 15 months of age. Then the child can make a straight line. This comes at 2 years of age. Remember, line has 2 points, so 2 years of age. Circle comes at 3 years of age. This plus sign, cross, 4 years. Rectangle, 4.5 years. Triangle, 5 years. Diamond shape, 6 years. A cylinder at 9 years and cube at 11 years. So these are the typical age fine motor milestones that the child can achieve. Coming to the next question. A child is noted to have established a clear preference for using their right hand. This milestone is typically fixed by 1 year, 2 year, 3 year, 5 years. So my question is asking whether this child is right-handed or left-handed. Right? We all have a preference. Most of us are right-handed. Some of us are left-handed. So when does this handedness comes? So remember the handedness, that is preference of one hand over the other, handedness, comes by 3 years of age. It is very different from left to right discrimination. What do I mean by left to right discrimination? At 3 years, the child just is using his right hand more as compared to the left hand. But it is at 4 years of age that the child would be able to tell that this is right, this is left. So this discrimination of left and right, it comes at 4 years of age. So here the examiner is asking handedness. So the correct answer here would be option C, that is 3 years of age. Moving on to the next question, discrimination between left and right sides of the body. This comes by 4 years of age, option C. Right? Now let's move to the next question. We have X-ray findings that show pencil-thin cortex and white line of Frankel. These are classical indicators of which of these diseases? Rickets, scurvy, achondroplasia, or osteogenesis imperfecta. What do you think would be the correct answer over here? Pencil-thin cortex, white line of Frankel. These are the typical X-ray findings of vitamin C deficiency, that is scurvy. So let's learn something about scurvy over here. So what happens in scurvy? There is vitamin C deficiency, and this is vitamin C is very important for collagen synthesis. Because of this deficiency, what will happen? There will be no hydroxylation of lysine and proline, and collagen synthesis would be hampered. And collagen, we all know, is the building block. So my skin would be affected, my bones would be affected, my hair would be affected, my blood vessels would be affected. The typical clinical feature you see because of the affection of the blood vessels is gum bleeds. You see subperiosteal bleeds, and because of that subperiosteal bleeds, the child is going to have very painful joints, won't be moving that joint. This is known as pseudo paralysis. And also the child assumes this flexed posture, that is known as flexed frog leg posture. You also see corkscrew hair, and at the base of the follicle there is hemorrhage. So corkscrew hair and perifollicular bleeds. And in typical rosary pattern that you see at the angle of the ribs, so painful angulated beading, this is corbetic rosary. If you compare it with rickets, then ricketic rosary is seen, which is just enlargement of this costochondral junction. They are painless and rounded, right? So this is the typical picture that you see in scurvy. You see a pencil thin cortex, there is subperiosteal bleeds, you have a ringed epiphysis which is known as Wimberger's ring. We have white line of Frankel. Just below this white line of Frankel there is a dark zone. This is Corbetic zone or Tremorfeld zone. And at the edges of this white line of Frankel is spurs. These are known as Pelton spurs. So these are the typical findings of scurvy. Remember, pencil thin cortex, subperiosteal bleed, white line of Frankel. Just below that white line of Frankel is scorbutic zone or Tremorfeld zone. At the edges of the white line of Frankel, you have Pelton spur, and epiphysis are ring epiphysis, also known as Wimberger's ring. Right? Then moving to the next question. A diet consisting primarily of corn, that is maize, can lead to the deficiency that presents with dermatitis, dementia, and diarrhea. The 3 Ds. This is caused by lack of which of the vitamin? Vitamin B1, B12, B3, that is niacin or tryptophan deficiency, and vitamin C. What do you think is the correct answer over here? The typical presentation, intake of corn, 3 Ds, this is nothing but pellagra, that is caused by niacin deficiency. So niacin deficiency is something which is very important for your exam. Let's learn about this niacin deficiency in a bit. So niacin, very important vitamin, B3. So niacin is produced from tryptophan. This tryptophan undergoes kynurenine pathway to form niacin, and the cofactor, a very important cofactor of this pathway, is B6. Also, this tryptophan forms other things like serotonin, and the serotonin can further form melatonin and 5-HIAA other metabolites. So, if there is tryptophan deficiency, what will happen? My niacin won't be formed. I will have pellagra-like symptoms. If my body is producing too much serotonin by serotonin pathway, my niacin would be deficient, right? Also, contents like maize, jowar based diet, they inhibit this kynurenine pathway, and that would again lead to niacin deficiency. So let's look at the causes over here. First is Hartnupp's disease. What happens in Hartnupp's disease? There is decreased absorption of tryptophan. So by decreased absorption of tryptophan, my niacin production will decrease and there will be pellagra-like symptoms. In carcinoid syndrome, there is increase in the serotonin production. So all of the tryptophan will be utilized in serotonin production. I will have niacin deficiency. Then comes B6 deficiency. B6 is very important for kynurenine pathway. So my pathway will get defected. And lastly, maize and jowar based diet. They have very high leucine content and this can block my kynurenine pathway again. Right? Similarly, a counter question they ask is raw eggs. If a child has been consuming raw eggs, then what vitamin deficiency would be there? So raw eggs contain avidin, which binds to biotin and can lead to biotin deficiency. Right, so this is all about your niacin deficiency and a pointer about niacin deficiency. Right, now let's move to the next question, another deficiency question. Bite dot spot. The bite dot spot ocular finding is classified by the WHO as X1A, X1B, X2 or XS. Now let's understand this WHO classification of vitamin A deficiency. We have X1, X2, X3 and XF, XS. So what is X1A? In X1A, there is just dryness of the conjunctiva. So there will be conjunctival xerosis. X1B, B stands for bite dot spot. This is the typical bite dot spot you can see over here. Right, so bite dot spot. Then we have X2 where you have now corneal xerosis. Corneal xerosis. In X3 now corneal ulcers are formed. X3A is corneal ulcer covering less than 1/3 of the surface area of the cornea. And after that, more than 1/3 of the surface area of the cornea. XF, F stands for fundal changes. So here you see fundal changes. And S is for scarring. You see scarring over here. So this is the WHO classification. We all know the treatment here is going to be oral vitamin A supplementation. If there is clear-cut sign of this vitamin A deficiency or any of these features, you give oral vitamin A supplementation on days 0, 1 and 14. So suppose a child comes to you today, you give 1 dose today, 1 dose the next day and 1 dose you ask after 2 weeks the child has to take. What is the dosage? If the child is less than 6 months of age, it is 50,000 international units. 6 months to 1 year, it's 1 lakh international units. And after 1 year, it's 2 lakh international units. Remember, there's a catch. If there is a child who is above 1 year of age, but the weight of the child is less than 8 kg, then you give half dose. Usually after 1 year, we give 2 lakh international unit. But if the weight of the child who is above 1 year of age is less than 8 kgs, then you give half the dose, that is 1 lakh international units. Right? So with that, let's move to the next question. What is the recommended oral dose of vitamin A for a 9-month-old infant during acute measles infection? So we all understand the dosage now. So it is a 9-month-old child. What will be the dosage? The dosage here is B. That is 1 lakh international units. 1 lakh international units. Right? Now let's move to the next question. We have a newborn weighing 850 grams. This newborn requires vitamin K prophylaxis. Each and every child requires vitamin K prophylaxis at birth. What is the correct dose and route? So we all know we give it on the anterior lateral aspect of the thigh, intramuscular dose. How much? If the child is less than 1 kg, we give 0.5 mg. After that, we give 1 mg. So this child is just 850 grams, less than 1 kg. So the correct answer here is going to be option A, that is 0.5 mg intramuscularly. Right? Moving to the next question, stunting. Stunting is anthropometrically defined as weight for height less than -2 standard deviation, height for age less than -2 standard deviation, weight for age less than -3 standard deviation, or MUAC less than 11.5 centimeter. So what do you think is the correct answer over here? Stunting means short-heighted. This is height for age less than -2 standard deviation. Right? Nothing to explain over here. Very appropriately, very to the point question. So let's move to the next question, which is on SAM. SAM is a very important topic for your exam. You Cannot afford to miss this. You should know the criteria, you should know the complications. So without further ado, let's start. So what is SAM? SAM is diagnosed if the child has nutritional edema or an MUAC of less than 13.5 centimeter, less than 12.5 centimeter, less than 11.5 centimeter, or less than 10.5 centimeter. Yes, the correct answer here is less than 11.5 centimeter. With that, let's just revise the criteria for SAM. Remember, to label a child as SAM, I need any one of the following. Remember, I need anyone. What anyone? First, there should be severe wasting. What do I mean by severe wasting? Weight for height less than -3 standard deviation. This is severe wasting. Second is MUAC. This MUAC is used for 6 months to 5 years of age. If MUAC is less than 11.5 centimeter, this child is SAM. And third is nutritional edema. That means edema that has nutritional cause. You have eliminated all other causes. This is nutritional edema. So any one out of these, I will call this child as a SAM child. Right? Let's move to the next question. We have a malnourished child that presents with voracious appetite and skin and bones appearance. This characterizes A. Kwashiorkor, B. Marasmus, C. Refeeding syndrome, D. Scurvy. So, skin and bones baby with a voracious appetite, this is classical Marasmus. With that, let's understand these two extreme forms of malnutrition, that is Marasmus and Kwashiorkor. So, look at this baby. Skin and bones baby. There is no subcutaneous fat. This child is sitting alert. If you offer food to this child will have a lot of food. If a normal child at this age has one chapati, he is going to have 4 chapatis, 5 chapatis, very voracious appetite. On the other hand, look at this child. Very edematous child, looking like a fat child, but this is actually a severely wasted child. This is just edema. This is a fat sugar baby. He's lying listlessly, right? Not alert, lying listlessly. If you offer food to this child is not going to have that. The child has reduced appetite. What do you think out of these, which is going to have a good prognosis? Definitely, child A, Marasmus child is going to have a good prognosis because the appetite is preserved. But the B child is not eating, has swelled up. This child has very poor prognosis. So with that, let's list down the differences between Kwashiorkor and Marasmus. Firstly, wasting. Wasting is present in both Marasmus as well as Kwashiorkor, but in Marasmus, this is very visible. This is skin and bones baby. So there is visible severe wasting. On the other hand, in a Kwashiorkor, this is masked by edema. The onset of Kwashiorkor is usually after 1 year of age when the diet is replaced by a very low protein diet. On the other hand, Marasmus can happen anytime. Deficit mainly here is protein. On the other hand, overall calorie deficit here is in Marasmus. Appearance, you all know edematous appearance. That is the fat sugar baby appearance you see in Kwashiorkor. On the other hand, Marasmus child is very cachexia. It is known as skin and bones baby. Appetite is lost, severely decreased in cases of Kwashiorkor. It is voracious appetite in cases of Marasmus. Prognosis here is poor in Kwashiorkor. It's good in Marasmus. If we talk about the additional features, then in Kwashiorkor you see a fatty liver. In Marasmus, you see a shrunken liver. Apart from that, there are certain skin and hair changes that we see in both of these extreme forms of malnutrition. More commonly, you see these with Kwashiorkor, but nonetheless can be seen in Marasmus too. Firstly, let's look at this picture, picture A. Can you see in the hair? There is pattern of pigmentation, hypopigmentation, hyperpigmentation, hypopigmentation. This is known as flag sign. Then we have this child B. There is peeling of the skin, right? So this peeling of the skin is known as, if you look at the skin, it will look as if a paint has been chipped off of the skin. So this is known as flaky paint dermatosis. And lastly, we have C, where again you see a pattern. This is known as crazy pavement appearance. Crazy pavement appearance. So all of these are skin and hair changes that you see in Kwashiorkor and Marasmus children, more seen in Kwashiorkor babies. With that, now let's move to the next question. What is the metabolic hallmark of refeeding syndrome that clinicians must monitor? Hyperkalemia, hypophosphatemia, hypernatremia, or hypocalcemia. So refeeding syndrome, remember, it is a very important complication that we see during rehabilitation phase. So what happens during rehabilitation phase? Now in rehabilitation phase, we are increasing the calorie intake, right? So we give high energy diet. So insulin production increased in the body to handle that high calorie intake. Because of that, what happens? You all know the effect of insulin. It pushes potassium into the cell, magnesium into the cell, phosphate into the cell. So there will be hypokalemia, hypomagnesemia, hypophosphatemia. If they ask you about the hallmark of refeeding syndrome, that is hypophosphatemia. Hypophosphatemia, right? So here what you are going to monitor, you are going to monitor option B, that is hypophosphatemia, right? Very simple. Now let's move to the next question. Which specific vitamin deficiency is of primary concern for the infants who are born to a strictly vegan mother? Vitamin A, vitamin C, B12 or E? We all know vegan people, they don't have vitamin B12 in their diet, which is mainly derived from the animal sources, meats, milk. So the correct option here is going to be C, that is vitamin B12. Moving to the next question. The condition acrodermatitis enteropathica that presents with perianal rashes and chronic diarrhea is due to the deficiency of iron, copper, zinc, or selenium. What is the correct answer? Yes, it's zinc. What is acrodermatitis enteropathica? It is caused by zinc deficiency. Acrodermatitis enteropathica. So this is an autosomal recessive condition where there is going to be malabsorption of zinc malabsorption. The mutation here is in this channel SLC39A4 that codes for this zinc transporter. Because of that, you see this typical triad where there is dermatitis, there is perioral and perianal rashes. So periacral or perioral rashes. There is alopecia and diarrhea. This is the typical picture that you examiner is going to give you. There is perianal rashes, perioral rashes, dermatitis. Right? This is nothing but acrodermatitis enteropathica. Moving to the next question. In the urine of a patient with phenylketonuria, that is PKU, the characteristic odor is described as burnt sugar, mousy, sweaty feet, or cabbage-like. Age-old question, this I think we have been studying since class 11th. There is mousy odor, option B, mousy odor. So let's just revise the peculiar odors that you appreciate in metabolic disorders. Firstly, we have multiple carboxylase deficiency, tomcat urine. We have glutaric acidemia, sweaty odor, phenylketonuria, mousy or musty odor, tyrosinemia, boiled cabbage, maple syrup urine disease, the name itself has maple syrup, so burnt sugar smell. Very important, peculiar orders of metabolic disorders. Following up with this question, again of metabolic disorders, maple syrup urine disease, MSUD. It results from deficiency in which enzyme? The option we have phenylalanine hydroxylase. We know this is the enzyme for phenylketonuria. Branch chain keto acid dehydrogenase. This is the enzyme responsible for maple syrup urine disease. Option B is the correct answer over here. Let's move to the next question. We have an adolescent patient presenting with a short duration illness and starvation. The lab results reveal that the unconjugated bilirubin levels have increased. There is unconjugated hyperbil, but the liver enzymes are normal. Which condition should be suspected? Rotor syndrome, Dubin-Johnson, acute viral hepatitis, or Gilbert syndrome? For that, let's just revise the congenital hyperbole conditions. So when we talk about congenital hyperbole conditions, we have unconjugated hyperbole and conjugated hyperbole. Unconjugated, remember two conditions, Crigler-Najjar and Gilbert, and in conjugated, remember Rotor and Dubin-Johnson. With that, there is a mnemonic that is DC motor. D is direct or conjugated bilirubin. If you reverse motor, this becomes rotor, and D is for Dubin-Johnson. So remember DC motor, you have a rotor syndrome, Dubin-Johnson syndrome that produces conjugated hyperbole condition. So the question here said that the child had unconjugated hyperbole. So remember these two conditions, Crigler-Najjar and Gilbert. Let's understand what happens in these conditions. I know for the conjugation of bilirubin, I need this enzyme UDP-GT. If this enzyme is absent or deficient, this is Crigler-Najjar. In type 1, this enzyme is absent. So I'm going to have very high levels of unconjugated bilirubin since birth. This child will land up into kernicterus. The management here will be exchanged, transfusion and phototherapy. On the other hand, we have type 2 Crigler-Najjar, where I have this enzyme, but this enzyme is deficient. So again, I'm going to have increased level of unconjugated bilirubin requiring therapy, but it won't be as high as type 1. Then we have Gilbert syndrome. It is actually the most common cause of inherited hyperpels. Here, what happens? By any illness, this is precipitated, right? So there is decrease in this enzyme activity with the illness. By stress, illness, this is Gilbert syndrome. So the scenario that the examiner has given us, that there is a short duration illness, starvation, and suddenly the bilirubin levels have increased, unconjugated bilirubin levels have increased. This fits my Gilbert syndrome. I know Rotor and Dubin-Johnson are going to have conjugated hyperbole or direct hyperbole. Right, so these are omitted. In acute viral hepatitis, I'm going to have increased liver enzymes, increase in the values of the liver enzymes. So again, this is omitted, and Gilbert syndrome fits perfect into the definition. With that, let's also revise our Dubin-Johnson and Rotor syndrome. These are conjugated hyperbiles that have congenital conjugated hyperbilirubinemias. So the defect in Dubin-Johnson is in the MDRP2 protein, and here the liver biopsy shows dark deposits in the hepatocytes. Coproporphyrin levels are normal. On the other hand, Rotor syndrome has organic OATP, that is organic anion transport protein defect, and the liver biopsy is normal. Urine coproporphyrin levels have increased. So this is all about congenital hyperbiles that you need to know. Let's move to the next question. DKA, diabetic ketoacidosis, is associated with which distinct breath or urine order? Cabbage, mousy, fruity, tomcat urine. We have just discussed about the peculiar orders, and we all know in diabetic ketoacidosis, it is a fruity order due to the ketone bodies. There is fruity order of the breath in the urine, right? Move to the next question. To prevent RDS, that is respiratory distress syndrome, the correct antenatal steroid regimen is dexamethasone 12 mg every 24 hours for 2 doses, betamethasone 12 mg every 24 hours for 2 doses, betamethasone a single dose, dexamethasone 12 mg every 12 hours for 2 doses. What do you think is the correct answer over here? Yes, it's option B, that is betamethasone 12 mg every 24 hours for 2 doses. Let's revise the antenatal steroid regimen for the prevention of RDS. So here we give a course of antenatal steroids over 2 days. For dexamethasone, the dose is 6 mg 12th hourly, so 4 doses is going to be there. Betamethasone, it's 12 mg 24th hourly, so 2 doses has to be there. So remember, the total has to be 24 mg. Dexa, small doses, frequent doses, right? So if you are giving dexamethasone morning, evening, you have to give that shot. So for 2 days, it has to be given. If it is betamethasone, that only one shot, maybe in the morning, maybe in the evening, up to you. So total 24 mg has to be given. This is the regimen for antenatal steroids. So the correct option here was B, betamethasone 12 mg every 24 hours for 2 doses. Moving to the next question, what is the mechanism of drug of choice, that is caffeine, used for apnea of prematurity? Beta-2 agonist, bronchodilator, adenosine antagonist, or anti-muscarinic action? So here the correct answer is adenosine antagonist. Let us revise apnea of prematurity. What is apnea? Apnea means cessation of breathing. So if I hold my breath, is that apnea? No. The correct definition is if there is stoppage of breathing, cessation of breathing for more than 20 seconds, or this cessation of any duration that leads to cyanosis or bradycardia, that is apnea. Right? The cause in newborns, premature newborns, is because of the immaturity of the respiratory center, and it usually manifests on day 2 to 7 of life. For the treatment, we give nothing but caffeine citrate. So how does it work? So normally adenosine in our body, it depresses your respiratory center and depresses the neuronal firing. If you give adenosine blocker like caffeine, what will happen? My respiratory center will be activated. That will increase the respiratory drive of that child. So there will be less chances of apnea. So adenosine blockade is the mechanism of action of caffeine citrate over here. So the correct answer here is C. Right? Now let's move to a very important topic, a very lengthy one too, NRP. So they're asking, according to the Neonatal Resuscitation Program, NRP, positive pressure ventilation PPV should be initiated within 30 seconds, 60 seconds, 90 seconds, 2 minutes. What is the correct answer? Age-old answer, golden 1 minute. What is that? 60 seconds, right? Golden 1 minute. So if a child needs PPV, it should be given within 1 minute of birth. So this is golden 1 minute. Let's look at this flow chart over here. So before birth, you have to do all the antenatal counseling, team briefing, equipment check. After birth, we ask the 3 questions: term, tone, cry. If answer to any of these questions is no, you are going to do initial steps of resuscitation along with the normal steps. You're going to dry the baby, position the baby, stimulate the baby, clear the airway if needed. Even after these initial steps of resuscitation, if the heart rate is still less than 100 or the child is gasping or apneic, then you start with positive pressure ventilation. This should be done within 1 minute. This is known as golden 1 minute. If after 30 seconds of this positive pressure ventilation, the heart rate is still less than 100, you perform the ventilated corrective steps. And if the heart rate is less than 60, you start with chest compressions. These are done 3:1 ratio. And if even after a whole minute of these chest compressions and breaths, the heart rate is still less than 60, then we give epinephrine every 3 to 5 minutes. Even if, and after giving these epinephrine, if the heart rate still remains below 60, then you have to rule out 2 conditions: hypovolemia and pneumothorax. If this is pneumothorax, needle thoracotomy has to be done. If there is hypovolemia, then obviously fluid resuscitation has to be done. And this is the target saturation table that you need to remember. Remember, now latest 1 minute saturation has been removed. We start with 2 minutes with 65. So 65 to 70, 70 to 75, 75 to 80, 80 to 85, and then in the 10 minutes it's 85 to 95. Right? So with that, now let's move to the next question. That is, the required chest compression to positive pressure ventilation in neonatal resuscitation is, we just read, it's 3:1. So I am going to give 3 compressions, 1, 2, 3, and then 1 breath. So this is 3:1 ratio. Total 90 chest compressions, 30 breaths. So this is 120 events in 1 minute. 120 events in 1 minute. Right? Now let's move to the next question. APGAR score. So they are asking which of these is not a component of APGAR score: muscle tone, pulse, heart rate, color, or respiratory rate. So let's learn the APGAR score. You can remember it by the mnemonic APGAR only. A is for the appearance of the baby. P is pulse rate or heart rate. G is for grimace. A is activity. This is respiratory efforts. Right? So appearance, if the child is blue or pale, you give 0. If the body is pink but the extremities is blue, 1. If the child is completely pink, 2. Then comes the grimace reflex. If no response, 0. If grimace is there, 1. If the child coughs or sneezes, 2. Muscle tone, if the child is limp, then 0. If there is some flexion, 1. If the child has good active motion, 2. Then comes respiratory effort. If there is no effort, 0. If the child has some irregular effort, 1. Maybe the child would be gasping. And if the child has good effort, the child is crying, 2. And lastly, we have heart rate or pulse rate. If the child's heart rate is 0, absent, If the child's heart rate is less than 100, 1, above 100, 2. So here you can clearly see muscle tone is there, heart rate is there, appearance is there, respiratory rate is not there, respiratory efforts are there. If no efforts, 0. If the efforts are slow, gasping respiration, 1. If good efforts, the child is crying, that is 2. Right, so D would be the correct answer over here. Moving to the next question. We have a term infant who develops respiratory distress 2 hours after an elective C-section. The X-ray shows perihilar streaking and fluid in the horizontal fissure. The diagnosis is surfactant deficiency, transient tachypnea of the newborn, meconium aspiration, or congenital pneumonia. Firstly, let's look at the question. A term baby, so very less chances of surfactant deficiency, and the child developed and respiratory distress after elective C-section. This is typical of TTN, that is transient tachypnea of newborn. And the X-ray also has typical features, perihilar streaking, that is known as sunburst appearance, and fluid in horizontal fissure. So let's understand these 3 conditions that we see in newborns. So we have 3 conditions with us. First is respiratory distress syndrome or hyaline membrane disease. Second is transient tachypnea of newborn. Third is meconium aspiration syndrome. So firstly, respiratory distress syndrome. Where do you see this? We see this in preterm babies. Why this happens? Because of the surfactant deficiency. And what is the X-ray that you see over here? We see white out lungs or ground glass appearance. An air bronchogram pattern would also be seen. Then we have TTN, transient tachypnea of newborn. This we see in term babies who are born via C-section. Because they're born by a C-section and not through the vaginal canal, there will be some fluid retention in the lungs. There can be some fluid retention, and because of that fluid retention, the child develops surfactant deficiency. So the child develops respiratory distress. This respiratory distress is very transient. Eventually, that fluid will be resolved and the respiratory distress will disappear. So here there is just fluid retention in the lungs and very transient condition, right? Transient. What is the X-ray feature that you see here? You see sunburst appearance. Sunburst appearance, that is perihilar streaking. And you see fluid accumulation in the horizontal fissure. Last is meconium aspiration syndrome. That would be seen when the child is in some form of stress or a postterm child. Because of the aspiration of the meconium, this child can either have a collapsed segment or can have hyperinflation. Otherwise, there can be some chemical pneumonitis like picture. So all of these things you will appreciate with mass. So depending upon the situation that is given, the clinical scenario that is given, my answer is going to be different, right? So let's move to the next question. What is the targeted preductal SpO2 of a newborn for 3 minutes of life? We just discussed the target saturation, starting with 2 minutes, 3 minutes, 4 minutes, 5 minutes, 10 minutes. We start with 65, 65 to 70, 70 to 75, 75 to 85. 75 to 80, 80 to 85, and lastly 85 to 95. So at 3 minutes, it's 70 to 75. Option C is the correct answer over here. This is the target saturation table. Remember the 2025 update. 1 minute has been omitted. We start with 2 minute target saturation now. Okay, now let's move to the next question. We have a 5-year-old child who is weighing 17 kg. He presents with diarrhea. What would be the amount of maintenance fluid required in 24 hours? 1000 ml, 1700, 1350, 2000. So we all know for calculation of maintenance fluid, we have this Holiday Segar method. How do we calculate the maintenance fluid? For the first 10 kgs, it is 100 ml per kg. For the next 10 kgs, it is 50 ml per kg. And for the next subsequent kg, there is 20 ml per kg. So here we have a 17 kg bacha. So the first 10 kgs, it will be 1000 ml. Then we have 7 kgs. So 7 into 50, that is 350 ml. So total maintenance fluid here will be 1350 ml. The correct answer here is C, 1350 ml. Right? So maintenance fluid is something that we all need. You, me, we all need. This is some bare minimum that you should have. We calculate this by Holiday Segar method, and the answer here is 1350. Right? Let's move to the next question. In which condition you see this classical Hutchinson triad? That is the Hutchinson incisors, malformed incisors, interstitial keratitis, and deafness. The options we have are congenital rubella, congenital CMV, that is cytomegalovirus, congenital syphilis, or congenital toxoplasmosis. So what is the correct answer over here? Hutchinson triad? No brainer. This is nothing but syphilis, congenital syphilis. So let's just revise important congenital infections. Let's start with CMV first. So if we talk about CMV, it is the most common infection that is seen in the developed world, and it is the most common cause of non-syndromic SNHL, that is sensorineural hearing loss. The transmission is maximum in the third trimester, and as you go further, primary infection, the risk of transmission is 30 to 40%. If it is a recurrence or reactivation, then very less risk of transmission, less than 1% is there. What is the clinical features that you are going to appreciate in CMV? Remember, 90% of the patients are going to be asymptomatic, only 10% is symptomatic. And in symptomatic patients, you see this triad: eye finding chorioretinitis, head finding microcephaly, and within the head, typical periventricular calcifications are noticed. So remember, CMV causes CMV. C is for chorioretinitis, M for microcephaly, and V is for ventricles, periventricular calcification. So CMV causes CMV. Moving to the next infection, rubella. Congenital rubella would be seen if there is primary rubella infection in pregnancy to the mother. In first trimester, if that's acquired, that will lead to severe manifestation. After 16 weeks, if the infection is acquired, typically no manifestations are seen. Here also you see a triad of eye finding cataract, heart finding congenital heart disease like PDA, and sensorineural hearing loss. Certain one-liners very important in congenital rubella syndrome that I want to discuss over here. Firstly, what is the most common congenital heart disease in congenital rubella syndrome? It's PDA, that is patent ductus arteriosus. But if I ask which is the most common overall manifestation, that is sensorineural hearing loss. Then they ask about the most common ocular manifestation. Though we have discussed cataract in the triad, but the most common ocular manifestation is retinopathy, salt and pepper retinopathy. And the late effects include expanded rubella syndrome, where the child has increased risk of diabetes mellitus, increased risk of renal abnormalities. So this is all about your CRS, congenital rubella syndrome. Now let's move to toxoplasma. Here the risk of transmission is proportionate to the trimester. That means the severity, the risk, the chances of more of transmission will increase with the corresponding trimesters. Lesser in first trimester, even more in second, maximum risk of transmission in third. But the severity is highest in cases of first trimester. Here the triad that we see is eye finding chorioretinitis, head finding hydrocephalus, and diffuse calcification in the brain. This you can confuse with CMV, right? Because very similar triads. So remember, in CMV you literally see CMV, that is chorioretinitis, microcephaly, and periventricular calcification. Here you see chorioretinitis, same. In CMV it was small head microcephaly, but in toxoplasma there is big head hydrocephalus. There it was periventricular calcification. Here in toxoplasma, diffuse calcification, right? Here diagnosis is made by IgM titer and PCR of the tissue. Treatment we all know is pyrimethamine and sulfadiazine for 1 year, and we should add leucovorin supplementation because we are giving pyrimethamine. And to decrease the risk of transmission from mother to child, spiramycin is given to the mother. So this is all about toxoplasma. And finally, let's move to our question, that is congenital syphilis. So when we talk about transmission, then the maximum risk is secondary syphilis. and maximum transmission is in the second and third trimester. Also, if the mother has syphilis, there are chances of recurrent abortions. Early signs you see here are hepatosplenomegaly, jaundice, anemia, thrombocytopenia. In bones, you can see osteochondritis, perichondritis, and because of these itis inflammation of the bones, you have pseudoparalysis. There can be bullous skin lesions and typical snuffles, that is persistent nasal discharge. It is in the late features that you see this triad, that is Hutchinson triad. You see this notched teeth, these are Hutchinson's teeth. You see interstitial keratitis and sensory neural hearing loss. Apart from that, there is anterior bowing of the tibia, that is known as Shaber skin. There is depressed nasal bridge, Olympian's brow, that is prominent forehead. All of these are late signs that you see in congenital syphilis. Diagnosis is by VDRL titer. It should be more than 4 times as compared to the mother's titer. The treatment is nothing but giving penicillin for 10 days. If the child is allergic to penicillin group, then we can try ceftriaxone. So this is all about the important infections. A short recap of all of these congenital important infections. Don't forget to revise before exams because this can be very confusing, right? We have studied at least 4 triads till now. So make a table if you are big on forgetting these. So make a table just to revise before the exam. What are the 3 triads that you see in all of these congenital infections? Now let's move to the next question. It is a follow-up question only. So most common cause of non-syndromic SNHL in childhood. Remember, where did we discuss this? We discussed this in over here, congenital CMV. It is the most common cause of non-syndromic sensory neural hearing loss. So here the answer is A, CMV. Okay, so moving to the next question. We have a 3-year-old child with 6-day fever, strawberry tongue, conjunctivitis. This child is at high risk of which of the following serious complication? Renal failure, coronary artery aneurysm, encephalitis, or splenic rupture. So what is this? 6-day fever, strawberry tongue, conjunctivitis, 3-year-old child. This is nothing but Kawasaki disease, and we all know important serious complication of Kawasaki disease. What's that? This is coronary artery aneurysm, option B. So let's revise Kawasaki disease. We all know what is Kawasaki disease. It is a medium vessel vasculitis. Typical age group less than 5 years of age. Males are more affected than females. What is the diagnostic criteria of Kawasaki disease? We need fever for at least 5 days, 5 or more than 5 days. Along with that, 4 out of the 5. How do you remember these 5? By the mnemonic GREEN. C is for conjunctivitis. We have bilateral non-purulent conjunctivitis. R is the typical rash. E is for erythema or edema of palms and soles. A, adenopathy, unilateral cervical adenopathy. And M is for mucositis, strawberry tongue. Right? And investigations, so we do blood investigations where we see elevated ESR, CRP, leukocytosis, thrombocytosis, and anemia. And one dreaded complication that we are worried about is coronary aneurysm. Apart from that, we can see myocarditis, arrhythmias, arthritis. So remember, Kawasaki disease is a very important topic for your exam, and don't forget the serious complication, coronary artery aneurysm. Right? So with that, let's move to the next question. We have a 3-year-old with diarrhea for 2 days. He's irritable and extremely thirsty. The skin pinch goes back slowly. What is the next step? IV normal saline, IV ringer lactate, oral rehydration solution, or oral juice. So what do you think? What this child has? Does the child has no dehydration, some dehydration, or severe dehydration? Let's understand. So firstly, you need to understand the dehydration assessment. Either the child won't be dehydrated, that is no dehydration, or the child will have some degree of dehydration, or the child will have severe degree of dehydration. So if I look at a child with no dehydration, here his eyes would look normal to me. The oral mucosa here would be moist. His thirst would be normal. That means if I offer water to this child, the child will very calmly, gentleman-like will drink that water. Right? So the thirst is normal. Just there is some ongoing losses. If we look at the skin pinch, because the hydration status is good, skin pinch will be instant. So recoil would be instant recoil, normal recoil. Here the management would be plan A. Plan A. Now let's move to some dehydration. Now the child has developed some degree of dehydration. So this child will be now irritable. Right? Eyes would look sunken. Oral mucosa would be dry. Thirst would be increased. If you offer water to this child, the child will very eagerly drink water. So this child is going to eagerly drink water. The skin pinch delayed, but usually less than 2 seconds. Here I am going to give plan B. Then lastly, we have severe dehydration. Now the child has severe degree of dehydration. So the child will be very comatose, lethargic. Eyes will look very sunken. Oral mucosa will be very dry. Because the child is now comatose, lethargic, would the child be able to drink water? No. Thirst would be lost. Skin pinch very delayed, more than 2 seconds. Here I am going to give plan C. Now one by one, let's understand these plan A, B and C. So we have plan A, plan B, plan C. One thing I know, in plan A and plan B, plan A, the child has no dehydration, the child can normally drink water. In plan B also, the child has some degree of dehydration, but the child can again drink water. So in A and B both, I am going to give just ORS. Just the amount of ORS would be different. In A, I have no dehydration. So just you have to replace the ongoing losses. So 10 ml per kg per loose stool would be given. Right? So for example, if the child is 10 kgs and passing one loose stool, so 10 into 10, that means 100 ml. So per loose stool, I will tell the mother of the child that as the child passes one loose stool, give 100 ml of ORS. Right? Then comes B, some dehydration. Here, along with replacing this ongoing losses, I have to rehydrate the child. That some degree of dehydration I have to correct. For that, I give 75 ml per kg of ORS over the next 4 hours. Right? And lastly, we have severe dehydration because now the child is comatose, cannot drink orally. I have to give IV. We prefer ringer lactate. Here we have to give 100 ml per kg in 2 parts, 30-70. Right? 30 ml per kg, 70 ml per kg. So if the child is less than 1 year of age, you give this 30 ml per kg over 1 hour, followed by 70 ml per kg over 5 hours. If the child is above 1 year, then I can give it fast. Over 30 minutes, this 30 ml per kg, and over 2.5 hours, this 70 ml per kg. Apart from that, ongoing losses, ensuring maintenance fluid, needless to say, would be the same. Right? So in this question, the child was irritable, extremely thirsty. These are the signs of some dehydration. The skin pinch is also going back slowly. What would be the next step? The next step is oral rehydration solution. This is some dehydration. So now let's move to the next question, Koplik spots. Where do you see Koplik spots? Mumps, measles, rubella, varicella. Very straight away question. You read it in PSM, you read it in microbiology, you are reading it pediatrics. This is nothing but measles, Koplik spots in measles. So what happens in measles? The cause of this measles infection is measles virus, which belongs to the family of Paramyxoviridae, single-stranded RNA virus. The incubation period is 10 to 14 days, and the infectivity is 4 days prior to the appearance of rash and 4 days after the appearance of rash. And the secondary attack rate is more than 90% over here. So what happens in measles infection? Initially, you are going to have some prodrome phase where there is fever, cough, coryza. After that, there is appearance of rash. This rash initially starts behind the ear, then spreads to the face, then to the trunk. And then it disappears also, leaving back a brownish hyperpigmentation. And again, a classical finding that measles infection is associated with this Koplik spots. Can you notice the Koplik spots over here? These appear 1 day prior to the rash. right? These are just adjacent to the molar, second molars, right? So these are Koplik spots that you see in measles. Apart from that, the examiner also wants to test some of the complications that you see in measles. Remember, the most common complications in measles is otitis media, and the most severe one is pneumonia. By the virus itself, if pneumonia is caused, it is known as Hetz pneumonia. If because of the virus, there is measles virus is notoriously known to impact my cell-mediated immunity. So if because of that virus there is secondary bacterial infection leading to pneumonia, then the most common organisms are Staphylococcus aureus and Streptococcus. And the famous late complication, how can we forget SSPE, that is subacute sclerosing panencephalitis. It is a lethal complication that is seen late, that is 7 to 13 years of infection. The child presents with decline in the scholastic performance and myoclonic jerks, typical dystonias, and ultimately death. So this is all about the measles infection. Now let's move to the next question. A genetics question. I have an infant with rocker bottom feet, clenched hands, overlapping fingers, micrognathia. What is this? Patau syndrome, trisomy 13, Edwards syndrome, Down syndrome, or Crigler-Najjar syndrome? Rocker bottom feet, clenched hands, overlapping fingers, micrognathia. Very typical of Edwards syndrome. So let us look at this Edwards syndrome. This is the second most common trisomy, where there is trisomy 18, E for Edward, E for 18. The occiput hair is prolonged, you can see, small head. Digits are overlapping. If you look at the feet, we have rocker bottom feet, right? Have you seen a rocking chair? The feet have that rocker bottom. Higher chances of congenital heart diseases like VSD, renal abnormalities, intellectual delays, and the most common cause of death in these cases is actually apnea or respiratory arrest. Right, so this is all about an important syndrome, Edwards syndrome. We have next question, Turner syndrome. In Turner syndrome, which cardiac anomaly is most likely to be found on 2D echo? Pulmonary stenosis, bicuspid aortic valve, mitral regurgitation, or tetralogy of Fallot. So in Turner syndrome, left-sided heart anomaly, bicuspid aortic valve is the most common anomaly. So the correct answer here is going to be option B, that is bicuspid aortic valve. With that, let's revise the important genetic syndromes and their associated congenital heart defects. Firstly, we have Down syndrome. What is the most common congenital heart defect that we see? Endocardial cushion defect. We have Turner syndrome and Noonan syndrome. Remember, in Turner syndrome, left-sided heart defects you're going to see. On the left side, I have left atria, left ventricle, aorta. So you see bicuspid aortic valve, coarctation of aorta. On the other hand, in Noonan syndrome, you see right-sided heart defects. On the right side, you have right atrium, right ventricle, and pulmonary pulmonary artery, so pulmonary stenosis. Then we have Edward and Patau syndrome. Edward is trisomy 18, Patau is trisomy 13. Here the commonly associated congenital heart defect is ventricular septal defect. Then we have Dye-George syndrome. In Dye-George, you see conotruncal defects. And then we have Williams syndrome, where you see supravalvular aortic stenosis. So very important high yield table, genetic syndromes and commonly associated congenital heart defects. Moving to the next question, which is the last question over here. We have a 2-week-old neonate who was brought to the hospital with the complaints of recurrent non-bilious vomiting. While examining the baby, the physician noticed a lump in the left epigastric region, which showed movement while feeding. What is the likely diagnosis of this child? Esophageal atresia, duodenal atresia, IHBS, or intussusception? So, typical question. We have recurrent non-bilious vomiting, a lump in the left epigastric region, and this lump is moving while feeding. What is the diagnosis over here? This is IHBS, that is idiopathic hypertrophic pyloric stenosis. Right? So let's revise this IHPS or CHPS. IHPS, idiopathic hypertrophic pyloric stenosis, previously known as CHPS, that is congenital hypertrophic pyloric stenosis. The name itself has said it, right? Hypertrophic pyloric stenosis. So the pyloric end of the stomach is hypertrophic. So that causes my gastric outlet obstruction. So this child is going to have recurrent vomitings. How these vomitings would be? Would these be bilious or non-bilious? These are going to be non-bilious projectile vomiting. And because of these multiple vomiting, what is going to happen? There is loss of water, there is loss of electrolytes, there is loss of my HCl, that is the gastric juice. So because of the loss of HCl, what will happen? There will be alkalosis, metabolic alkalosis. There will be hypochloremia. Because of the loss of sodium and water, what will happen? My RAS would be activated. That will again, what will that do? That will, by the activation of RAS, what will happen? There will be outflow of H plus K plus and conservation of sodium. So there will be hypokalemia and H plus would be excreted into the urine. My body is already losing H plus, right? There is alkalosis in the body. Body should conserve H plus, but there is loss of H plus in the urine. That's why this is known as paradoxical aciduria. Paradoxical aciduria, right? So there is hypochloremia, hypokalemia, metabolic alkalosis with paradoxical aciduria. This is what you see on ultrasound. If the thickness of the pyloric end is more than 4 mm and the length is more than 16 mm. This is diagnostic of CHPS, and the management here is dehydration correction and finally surgical correction by Ramstad's pyloromyopathy, right? So this is all about our session, a TnD session. With that, we wrap up the 50 questions of pediatric discussion. The important topics I have highlighted: you should know the normal growth and development pattern, you should know dehydration assessment, you should know these tables, congenital heart defects, IHPS is a favorite question of the examiners, the congenital infections, these are very favorite, and certain spots over here, pointers over here like complex spots. These are something that examiners frequently tests. So remember simple things, frequently repeated topics, previous year questions imply for both NEET PG and INICET. I hope this session was helpful. With that, if there is any doubt till now, you can drop that down in the comment section and we can take that. If there is no such doubt, we are going to wrap up this session. Okay, so if there is no doubt, then thank you. Thank you for being so cordial throughout the session and being so interactive in the comment section. We can now end this session. Thank you.